My duty is to not to stand too much between you and the well-awaited lunch and the Sunday afternoon. So let me invite my panelist, Dr. Santosh, Dr. Deepan, Dr. Sahil Gupta, Dr. Kinjal, okay. Dr. Ambasan, Dr. who's not there? Dr. Gagan. Gagan is there? No, he must be upstairs, no?
मतलब वो दोनों ऊपर थे तो बोले हम एक आ जाएंगे.
Okay.
रेडिएशन का ऊपर चल रहा है वर्कशॉप. And
okay, fine.
Sir,
so
instead of the last,
we have all the medical oncologists, right? Fantastic.
Sir, one more medical oncologist was the last minute add.
Yeah, please. So we have all medical oncologists. Fantastic. So anyways, we are talking about small cell lung cancer. So it's mostly all medical oncology only, but still. So how I treat small cell lung cancer in 2025, why we chose this? Because a lot of newer advances have happened in small cell lung cancer treatment in this ASCO, and I thought we should able to cover that. Whether those newer advances will reach to India in 2025 is a question, but at least as a medical oncologist, we should be aware about them. So that is why I have no conflict of interest, and Dr. Sahu is also not here, so I have absolutely no conflict also. So let us start. It's a lucky Monday morning case. What is lucky Monday morning case? That means you are sitting in your OPD and you get a bana banaya, all diagnosed, well worked up case, and that too a rich man. So affording man. So this is like everybody wants that. So it's a 51-year-old male, biopsy proven small cell lung cancer, performance status is 1, he is fit medically. Unfortunately, he has a PET scan report which is showing a lung mass from which the biopsy was done, and it is small cell lung cancer. He has unfortunately liver mets 3 in number and adrenal mets 2 in number. Yes, he says that I can get a moon and you have to get me well. So now, the moment you say that, oh, you can do everything, sometimes that becomes a problem. No? We are happy when patient says, no, financial issues are there, so we write on paper, oh, financial issues are there, so this is discussed, and patient is saying, I don't want to. So your job is done. But the problem occurs when the patient says that I can get moon also. Then you have to think whether you have to get moon, Neptune, Uranus, Jupiter, or because you can get anything. So let us understand. So what are the more investigations that we would like to do? We would like to go for MRI of brain, or PDL1 marker, or NGS, ctDNA. So we'll start with Dr. Pushpendra. What we like to do? You can do anything.
MRI brain.
So you will not go for NGS?
No, sir.
No, you will not go for PDL1 also?
No.
And no ctDNA?
No, sir.
Are you sure?
Sure, sir.
Okay. Please. We'll go from this side to that side. Everybody, please give their answers. Patient can afford everything, and he has come to you. He is a rich man.
Well, right now we are doing only MRI brain. We don't see any benefit of doing anything else, especially even for a NGS. Right now there are no approved therapies for a small cell, especially, and we don't see any particular targets in a small cell. So we just finish with the further investigation.
So you are
MRI
not of the
brain.
believer that you will not get the tissue on progression. So you should have all the mutation analysis at the baseline.
So
you are in Viraj's meeting and you don't want to do NGS.
So if at all we want to do, we can always do NGS later. Even if there is a progressive disease.
So you will do the liquid biopsy if the tissue is not available.
Yeah. See, and secondly, the chance of having a target in a small cell lung cancer is very, very, very low.
What about DDL3? Have you heard of DDL3?
So that's what I'm talking about. They are very rare. It's not very common, and how we can
so
be
upfront you will not like to do it, and later whenever. What about what's your thought?
Sir, same MRI brain only. Upfront, I am also not doing NGS or PDL.
If everybody is offering the same, how the patient will return to you? Yeah, he has gone to 2 oncologists. They are doing the same thing. You have to do something different. So MRI brain.
Yes, sir.
Okay.
Same, sir. MRI brain in comorbidity assessment.
He's fit. He's fit. It has already been declared.
No,
MRI brain only.
Yes.
What about you?
Same tarah. Confirm the diagnosis and then continue with the.
So diagnosis is confirmed. Oh, Dr. Gagan is there. So now we have some balance. We have 5 medical oncologists and 1 invited radiation oncologist for a small cell lung cancer panel.
Real world situation, intent to treat scenario hai.
Fantastic. So now we will just revise the case for you. It's a lucky Monday morning case, 51-year-old male, biopsy proven small cell lung cancer. कोई झंझट ही नहीं है, biopsy हो चुकी है, fit है, PS1 है, rich है, PET scan हो चुका है, lung mass, liver mets, adrenal mets, unfortunately. तो आप क्या करोगे आगे? Will you like to get an MRI brain?
Yes, please.
And what about the NGS PDL1?
I'll let you decide.
What are you saying?
I will let you decide about it.
No, the patient has come to you. It's your lucky Monday. You are the head of the department. The patient has come to you.
Okay.
Now you have to decide. You are calling shots.
I'm honestly, I'm not sure about the real validity of PDL1 because that's something that continues to sway between relevant and not relevant.
So small cell lung cancer looks to be extensive stage. Will you like to do
I think
PDL1?
PDL1 is not really required in small cell lung cancer is my guess. If I have to take one.
So you will not order for it?
I will definitely go for NGS, no doubt on that.
You will go for NGS?
Yeah, why not?
See, that is the difference. That is why he is head of the department and you are not. So he is getting an NGS done. But what are we going to gain? See, all of the rest of the 5 said that there is no point in doing NGS in small cell lung cancer. One person said that rightly that there are no actionable mutations. So why are you doing it?
Perfect. Then I'll not do it then.
Okay, so you have changed.
That's
That is the
perfect.
power of
That's
MTD.
perfect.
So molecular tumor boards are, you have to raise your voice and then you get what you want to do.
Yes.
So anyways.
No, but seriously, I mean, what is the, what are you really investigating with NGS or PDL1 to that matter? I joined in late. Actually, I thought the panel is on first floor. I was there. So then I came to the ground floor.
Fantastic. So thanks for joining us. So basically, the take-home message for residents here is that MRI brain is compulsory. NGS, of course, there is no role upfront. ctDNA, of course, no role upfront as of now. PDL1 is something of course, as I said, we generally don't look for. But suppose the patient has already have a report. No? After some time he shows, no, doctor sahab aur ek report karwaya tha. He is PDL1 negative and MRI brain no abnormal detected, NAD. What is the treatment? How will you treat him next? We'll start from MRI brain is negative, so you can still do something. Would you like to do something?
He already had liver
No, I'm talking about Dr. Gagan.
So I think the patient is having metastasis. So we'll let the systemic therapy start first.
Okay.
And then maybe later on we can think about the controversy between doing PCI or not doing
We'll come to that. We'll come to that. Okay,
later.
fine.
Yes.
Fine. Please.
So it's already extensive stage small cell lung cancer with liver and adrenal mets are there. So I proceed with systemic therapy. I explained about chemoimmunotherapy option for him. So with the carbo-eto with plus or minus Atizo or Durva based on the options available.
So which one will you give, Atizo or Durva?
So if the patient is extremely rich,
No, patient is already rich. He has said he is rich.
If he is affordable for each and everything, then I go with carbo-eto Atizo, and then later on I try to add lurbinectin as a point of maintenance therapy.
So you will start with carbo-eto Atizo.
Yes.
And at the
Patient is having a good stable disease.
Then you
as a
ditch the
maintenance.
Atizo and you will start on Durva.
No. I put on lurbinectin also, no?
Okay, so
No,
you are
it
saying chemo plus Atizo.
Immunotherapy.
Ah.
That is atezolizumab. And then once the patient is having stable disease, then I go with maintenance lurbinectin also along with atezolizumab.
Okay, what about you?
Sir, I would like to start adipocyte carboplatin Atizo 4 cycle, and then would like to reassess if response stable disease or partial response. I would like to add
First, will just tell me what we do to start with, because response will come to later.
Yes,
What
sir.
will start? We will start with Atizo.
Atizo carb and adipocyte 4 cycle and reassess.
Patient is affording for everything. What we will start?
Sir, chemo IO combination.
Which IO?
I have used Tezo a lot, but with Durva I have had comparatively better results.
So you think that the Durva has better results? So you will give Durva?
Comparatively.
So you will give Durva or Atizo?
Yes, sir.
And I'm asking you, which one will you give?
Durva I will give.
So 2 for Atizo. Radiation oncologist is already referred nicely because his role will come later. 2 has gone for Atizo, 1 for Durva. What about you?
Till date, we have used only Atizo, so we go with Atizo plus carbo plus.
I have no conflict of interest, but these people have conflict of interest. They all want to use Atizo. What about you, Pushpendra?
Sir, we have used both. I would prefer Durva because for maintenance later on, it would be a 4-weekly schedule, so it would be convenient to continue.
So
that.
you have a point saying that you will use Durva because the maintenance is 4 weekly. What is the Atizo maintenance?
3.
3 weekly. So you want your patient to come 4 weekly. You want him to see you less or less frequently. Something like that.
Convenient for them also.
Convenient for them also. So basic point here is that I have just taken this slide to show that the data technically for IMPAR 133 and Caspian is more or less same. And they all are equally good or equally bad in PDL1 negative. Okay. We all like, we don't check PDL1 because the approval is irrespective of that. But we know in bottom of our heart that if PDL1 is positive, the patient may do better. But what my point is that the choice of Atizo or Durva as an IO agent in a patient who can afford everything is probably individual subjective preference. And at the right point that he said that sometimes maybe the maintenance later on may become easier with Durva with 4 weekly, especially if you are not convinced with the lurberectidin's data. So for the residents in the or the fellows in the group, you can choose either. It depends upon the toxicity profile, which more or less same for both, and what is your personal comfort. So I think we have 3 versus 2 and 1 neutral. And the moderator says yes.
We don't have any bias.
We don't have any bias. Moderator also doesn't have any bias. So we can use either. Moderator has shown both the ways. Now there comes the question, Dr. Gagan, is there a role? MRI is normal. They have given systemic therapy, 4 cycles. Will you like to go for prophylactic cranial radiation? Yes.
Okay, so first things
In a
first.
51-year-old fit patient, he can afford everything.
Yeah, he can afford everything and he wants the best treatment.
Yes, he wants the best
presume
treatment.
that. So first things first, the standard of care is PCI. So that should be very clear to the audience, especially the residents who are sitting there. But this paper and the practices that have evolved after this one, they do say that a 3-monthly MRI, this paper was very clear, a 3-monthly MRI had to be done and you had to chase. And then the paper was still little clear, but the practices are still not very clear as to, once you get those metastases, then what to do, because now the thing is evolving to SRS for those metastases. So, sorry.
No, so the patient is saying that I can afford everything.
Yeah.
How will you explain to him that because he is well read, so he probably has searched this on Google.
Sure.
And he's asking you, okay, doctor, there is no difference in the progression for survival OS. Why are you radiating my brain?
But see, the benefit of eradicating brain metastasis may not always come with overall survival or something like that. It will come with the quality of life deterioration that can possibly come with the brain metastasis. Just for the sake of clarity, one should know this. But if a patient is willing to undergo a 3-monthly MRI very, very strictly, I don't mind omitting PCI in that patient and even chasing the metastasis with SRS.
So in your practice, in real world situation,
Yes.
suppose you get 10 patients who are all affording, how many go for PCI, how many go for observation?
I'll tell you, there are patients whom I explain that, okay, this is what we are getting into. And please remember that the MRI, 3-monthly MRI is not so easy, get it done. Patients will naturally say, ki, Dr. Saab, let's get it done after 4 months or something like that. All those things happen.
So compliance is an issue.
So compliance
according
is
to
definitely an issue. And this is one thing. The second thing is that eventually, I remember, I've not kept data, but most of them eventually get metastasis, and then one of them will ask for an SRS or something like that. Someone will be fine with the whole brain.
My question is, upfront, if you get 10 such patients, how many actually go for PCI after your counseling?
Well,
Percentage-wise?
the literature is very clear that 30% of your metastatic are going to get brain metastasis. That is why PCI is the norm, right?
Yes.
30% and some reports say 40% are going to get brain. So your answer is 4 out of 3 or 4 out of 10. That's very clear.
So
it's not going to change.
So upfront, how many of your patients prefer the MRI surveillance? That's my question.
Well,
and how many prefer the upfront therapy
do.
over surveillance?
Some do. Everybody does. Everybody is willing to not take radiation, but they want a discussion. When we discuss with them about the clarity, so everybody in this audience knows that, okay, this paper is there and this. So that's what I'm coming to. Please understand that avoiding PCI is like putting your patient in a little bit of risk of getting brain metastasis, and getting those brain metastasis has a risk of seizures and an overall bad taste for the patient.
So to cut short, you will prefer for PCI?
I will be very clear with the discussion. No, it's not my preference. I will be happy with 3 monthly MRI and follow up.
Okay.
I'm happy because this paper supports it. This is a robust data, but there is a lot more riding than just a simple thing.
Dr. Ambersand, what you will suggest to your patient?
Sir, most of the time giving PCI in this scenario will be very challenging. Patient getting fitness and all those things, extensive lung stage disease, with the kind of fitness after chemotherapy for PCI is, we won't see very often.
So observation or observation and surveillance MRI versus PCI, what you will do?
I will discuss with the patient clearly about the risk of brain metastasis and then close follow-up with the MRI. And if the patient is definitely fit, I slightly prefer more PCI rather than going for observation.
So 2 people for PCI?
Yeah.
PCI or versus observation and
observation
MRI
is this patient will be remain in follow-up.
What are you saying? Sorry?
I am going to offer ATESO maintenance. So this patient will be remain in follow-up. Asymptomatic patient, no point in
So you go for surveillance. Surveillance versus upfront PCI.
Sir, PCI, asymptomatic
So 3 versus 1.
prophylaxis and symptomatic brain mets, better to go for PCI.
Gagan, you are finding the potential medical oncologist who you can get to your institute. They are all friendly.
Give or don't give PCI is not my contention, but understanding the issue is the real thing. Like you rightly said, that you have to see what's a person can be very happy. Okay, doctor साहब ने RT बचा ली, but they have to understand what they are really getting into. They are getting into a potential.
So full disclosure discussion with the patient is necessary.
It should be a very clear discussion.
Okay. Yeah. What about you? What you will prefer?
So again, personally, I would give a MRI as an option. Surveillance as an option.
So you will prefer MRI surveillance?
Preference. But at the end of the day, we have to discuss both the options. Okay.
Yeah, you will discuss, but you will prefer MRI.
Yes. If patient is anxious about the disease, we would go for PCA. If patient is not anxious and he had a very good response, complete response, as well as no upfront brain metastasis, and he is going to take ATESO maintenance. So these are good indicators that he can frequently come to us.
Okay.
So this is where we can actually plan MRI surveillance.
So you will discuss, but your MRI surveillance, you are also okay for MRI surveillance. Yes. What about you, Pushpendra?
Same, sir. Compliant patients, observation. If seems difficulty in compliance, PCI.
So basically, house is divided. But what I want to suggest to the fellows that, as Dr. Gagan has rightly said, we have to discuss, because sometimes the patient may not understand that what exactly happens when brain mets occur. Suddenly he may get seizure. Suddenly he may have a fit when he is driving. So many things can happen. So you have to make sure that you discuss both the options and keep it an individualized decision and document the decisions very well. You want to add something?
Pacific trial, they try to see whether PCI is making difference in those
No,
populations.
it is not making difference.
It is not showing difference.
So that's what I'm saying.
It's up to individual decision only. We have to see the patient is fit and
yes. So basically that we have to discuss and document and tell the patient both the options and let the patient decide. So now, after 6 cycles, again you are still being lucky that the PET scan is in CR, the PET scan is completely CR, no toxicity. What you will do? Will you continue chemo plus IO? You will stop chemo after 6 cycles, continue IO, you stop both chemo and IO, or continue IO plus something else? We'll start from Pushpendra.
So till now, I would like to continue IO, stop chemo, but we have now data about adding a lurbinectidine with IO. So that I will discuss.
Okay, so suppose the patient can get the moon, na? He said that I will get that. Forget the approval, Dr. Saab, I can get it from abroad. Then what?
So IO plus lurbinectidine maintenance.
So you are convinced with that data?
Yes.
What about you?
As I don't know how many of us actually tried lurbinectidine. I'm not sure about that.
No, the patient says that Dr. Saab, I can get it from abroad. Whatever drug that you want, I can get it.
No, I got it. Like what I'm trying to say is, so my decision to add lurbinectidine is based on what is the tolerance of chemotherapy. How many times he developed febrile neutropenia? How was
he has done well. He has done well. He has gone into CR.
Well. Then we may consider adding lurbinectidine as an option. We must discuss, because again at the end of the day, the most common side effect of lurbinectidine is hematotoxicity. So we need to check on that. So if patient is okay, adding one more agent.
So you will stop chemo, you will continue IO, and you will discuss the data of lurbinectedin. That's what you're saying?
Yes.
And you will not wait for the approval for the lurbinectedin. You will
I
not wait
don't
for the
push-
approval.
I don't push him for lurbinectedin. I will explain the option addition because it is adding a benefit of a month or so in terms of PFS as
Okay.
of now. And we don't expect much for these kind of diseases.
Okay.
So that is what we are also adding toxicity. So it might, because of the toxicity, he might need additional admissions.
Okay.
He tolerance might go bad as like the more continuous chemo you push,
Fine.
and at the end of the day.
Fine.
So yeah.
What about you?
Sir, I would consider continuing IO only.
IO alone. You're not sold out on lurbinectedin yet.
No, sir.
Those people have not contacted you yet. No. Okay, fine.
Even if they contact, I'll not do, sir.
No, even if they contact, you will not do. What about you?
Sir, I would like to discuss option of lurbinectedin, and if agree, then I would like to offer as tolerance with the 6 cycle of chemotherapy in IO was very good in this
Okay.
patient. So
What
I think in his case, the issue has been discussed, hematotoxicity would not bother. So I would like to discuss option of lurbinectedin. If patient is willing, agree, then I would like to offer both.
Okay. So Amberson, you must have seen this data, right?
Yes, sir.
So I am Forte trial, and what they have done is they have added lurbinectedin. But are you happy with the design?
Maybe the control arm with lurbinectedin as a separate arm, that is also because basically they are introducing a second line treatment into the maintenance setting. And then
Correct.
checking
It is
for
already
that.
approved for second line. You are trying to get it earlier. So what is something that they should have done if they wanted to see the real effect of getting the thing early?
Maybe the third arm with lurbinectedin alone.
Okay. Anything else? Something that is obviously highlighted. They did not allow crossover. They did not allow crossover for something which is already approved and on progression in a second line. They did not give that. So that is a big criticism of this trial, which unfortunately, of course, we can only discuss, but we cannot do anything beyond that. But the crossover was not allowed, which is a big problem. But it showed OS benefit. And it showed an OS benefit of reasonably good amount, around 3 months. In an extensive stage small cell lung cancer, 3 months is a big number. But as they have rightly said, that 9.1% only effective crossover road. That means part of a trial they did not allow it, but people opted out of the trial and tried to get that drug. So they have analyzed that data and they come to know only 9.1%. 9.1% is too small number for us to be happy. At the same time, so 63% of patients who discontinued maintenance therapy went on to any second line therapy. So there is some discussion about toxicity. So Dr. Amberson, what's your take on the toxicity?
Sir, in a maintenance setting, too much of toxicity will be a difficult thing to carry forward for the patient.
So are you happy with the toxicity of the additional? Do you think it is manageable toxicity, or it is not significant toxicity, or according to the significant toxicity?
In a trial setting, serious adverse event of 30% is really significant. In a
Yes.
real world scenario, it turns out to be 40-50% also.
So grade 3, grade 4 adverse events were increased from 5.8% to 25%, if you see, and serious adverse event from 17% to 31%. So if with these kind of things, the question to all the medical oncologists, starting from Pushpendra, you have this data, patient says that, okay, fine, I am fit, I can get the drug, but are you happy with this particular thing? When the serious adverse event, not just the minor ones, the serious adverse events have doubled.
No, sir, because in maintenance setting, as the panelist said, it's significant. So definitely patient's quality of life and those things will be disturbed.
But then you're not going for the OS? 3 months OS, statistical significant.
The thing is, sir, we have not seen such significant improvement in first line over last few years in extensive stage small cell lung cancer. So these findings are significant, but definitely toxicity is also considerable.
Are you happy with the performance of the control arm in this trial? 10.6 months? Is that your reasonable expectation? Or do you think the control arm also has underperformed in this trial?
Little underperformed.
Anybody has any comment? Crossover we have
In the-
discussed.
in the
Toxicity
original
we are
trial,
discussing.
both Durva and Redizo arm showed a median survival of about 12 to 13 months.
So here it is 10.6 months.
It is only 10.6 months.
So, do you
So,
think that the trial results are because, of course, crossover was not allowed, and plus somehow magically during the trial the control arm has underperformed? What are your thoughts on that? I'm not saying it has. What are your thoughts?
So these are
Because I'm showing the number 10.6.
So again, at the end of the day, it's a cross comparison, which we should not do in the first place. For this particular aspect, maybe we should look at the further details into the study. How
So we'd like to see the full publication of the
yes,
paper. Any other medical oncologist, please? What about you?
Yeah. See,
In the
given an option, whenever the patient who want to survive, he want to survive with a good quality of life rather than just.
So more than the control arm, you are worried about the toxicity part.
Yes, I'm worried about the toxicity. That's what I discussed initially also.
Okay.
So I am not in for it.
But do you think that the toxicity will be less when his performance status has deteriorated because of progression? Because you are going to use it on progression. So that time he may have more toxicities because anyways the PS has gone down because of the progression. Then what?
Anyway, at the end of the day, we must understand small cell lung cancer, the second line options are not great. We have to understand that. So the best shot is your first shot.
So now will you like to change your mind?
No. Best shot is the first shot with a good quality of life. That is what I am trying to say. I am not trying to say I will put lurbinectedin in the first line. I am not saying that. So if that is impairing the quality of life, I won't give lurbinectedin also.
So basically you will start it, but if it start having toxicity, you will stop it. That's what you're saying?
Exactly.
So now you have changed from not giving to at least give it and then stop.
Again, see, it is all, every time, it all a individual to individual based discussion. We cannot, concretely we can say, no, for all patients I would give, for all patients I don't give. So it is always a discussion based and always a patient's approach. What patient wants at the end of the day.
Fine. What about you? Are you comfortable with the trial results of this particular trial? Because you wanted to give. And what about the toxicity? How will you manage it?
Sir,
Or are you
I would be
happy?
giving this Atezo only because of the 30% side effect profile.
You were initially giving or not
No,
giving?
sir, I was IO alone.
Okay,
So
I
he said
alone.
that
Fantastic.
lubricant guy haven't contacted
fantastic.
me.
Can you give it the other one, please? He wanted to give both. So what about now?
Yes, sir. I had initially also discussed. We'll discuss with both the things, pros and cons. Though as you rightly picked up, the glitch is there. As we can conclude, is rightly not crossover allowed, and 3-month OS benefit. But reasonably, quality of life is again that quality that we want. So with that.
So Dr. Amberson, do you agree with the conclusion? For the first time, I was very happy that in the ASCO slide they mentioned cost. Otherwise, they never mentioned in ASCO slides cost. Of course, these are slides taken from ASCO discussion. And the discussion very nicely said that the OS has improved, but toxicity is not trivial. Again, they are very diplomatic. They are saying it is not trivial. They could have easily said it is significant. Not trivial and significant are two different words, but something that becomes double should have been considered as significant. But they have said not trivial. So practice changing data, but patient selection for this regimen will be key. So those who are in the audience and fellows, this is how you have to be diplomatic. When you are in a conference or you are gathering to a larger audience, this is how you should use the words. Toxicity is not trivial. Practice changing data, but patient selection for this regimen will be key. That means you are not committing either side. So Amberson, what is your final take home if on this particular trial? Are you happy with the trial design? Are you happy with the toxicity? Overall, do you think it is going to be a practice-changing data?
Sir, overall the disease biology itself, it's a really bad disease. The patient should understand that the disease biology is really bad, and adding any form of therapy, maybe it is a short-term relief. It is not going to be long-term relief. This point should be informed to the patient, and based on their willingness, how long they want to continue, how long they want to handle the toxicity, because both overall survival as well as quality of life, both are important for the patient, and what is their stress on it, based on which we have to take a final call.
So basically take home message is that it is, of course, the 3 months OS in small cell lung cancer cannot be ignored, but at the same time toxicities are more. In India, of course, the cost issue is going to come. So even though it is a good data, whether it will be, what will happen in real world, that will come to know maybe after 1 or 2 years when actually people start using it, earlier setting, and then probably will come to know. But as everybody rightly said, this option has to be discussed, especially sooner the approval will come, and that time it becomes compulsory to discuss. So moving on, the patient has taken only IO, he has not taken anything else. After 8 months, he has progression in brain, 3 lesions, no other meds. Now Dr. Gagan, he is slightly feeling happy. Oh, I had already told this is going to happen, but now it unfortunately has happened. So now how will you treat? You will offer surgery, only 3 meds, or you go for SRS, whole brain RT, or you, okay, will not do anything. Of course, you will do something.
Sure.
So first 3 options.
So I am not smiling because of the fact that metastases have occurred. I am smiling at the prospect of the kind of discussion you have actually planned in your mind by all these options.
Okay.
That's what made me smile.
Okay, fine.
Because I can seriously foresee a very good discussion. So in this scenario, again, the discussion is mandated with the patient. He has
progression only in brain.
Only in brain.
Rest, everything is okay.
Yeah.
He is fit. He is not symptomatic, but MRI surveillance was being done, and that has picked up 3 brain lesions.
So again, we actually can do whole brain RT with simultaneous integrated boost with PCI integrated as a whole brain RT. But there is a scope for doing SRS that would be preserving to his quality of life if the patient continues to get that 3 monthly MRI done.
Okay.
So there is no harm.
So let me summarize. Surgery is definitely out for you.
Unless it's a very large lesion, say 4 centimeter or so, generally that doesn't happen if your surveillance is good. So I am presuming that
They are
that
small
is not the
lesions.
case.
They are small lesions.
If your surveillance is good, you will not find a 4 centimeter
I
lesion.
agree. They are small lesions, 1 centimeter, 1.2 centimeter. So you will not like to remove them.
No. There is no role for surgery for such small lesions.
No surgery.
No
Okay.
surgery.
So amongst the next 2 options, which will you prefer? Patient says, tell me one option, doctor साहब आप बोलेंगे वो करेंगे.
So I will suggest that now that you have metastasis, there is a reasonable chance that you will have the distant brain failure if I do SRS. So best option would be to do whole brain RT with SIB. But with the whole brain RT with SIB means simultaneous integrated boost, that is giving a slightly higher dose to the lesion. But the problem is again the same thing with PCI, that 4 months down the line there is a possibility of your higher functions deteriorating, and the fact that the chap has systemically NED, and probably all you are throwing in even the 3rd line chemotherapy is in the 1st line, calling it maintenance. Okay, touche there.
So tell me, what you will do? You will do SRS with...
So I can offer SRS, but the only strong contraindication for SRS in my mind will be a lesion which is close to the meninges or some doubt in the meningeal lesions.
Okay.
Then I will say that let it be.
Okay. Anybody in the remaining medical oncologist, you have neurosurgeon friend. Anybody would like to take these lesions out? Small lesions, 1 centimeter, not big, in a safe area, not in the cerebellum or anything. Any one of the medical oncologist? Nobody's wife is neurosurgeon.
Surgery will not be
Nobody's wife is neurosurgeon, right? So that is out. But still no neurosurgery.
Definitely no neurosurgery.
Anybody wants to go for neurosurgery in the panel? Oh, nobody. So, see, Dr. Gagan, I'm telling you, these are the good candidates. You can choose somebody for Yashoda. You are the best. No, I am the best. Fine. So, yes, we will, of course, generally we don't opt neurosurgery in an extensive stage small cell lung cancer, even though the patient is in remission and fit. We, of course, go for SRS. My final question to Dr. Gagan, what about the P? P for proton. You will offer proton, he can get the moon.
You mean proton beam therapy for this?
For this particular patient, is there any role of proton?
No.
And he says, Doctor साहब मेरे पास बहुत पैसा है, मैं चेन्नई उड़ के जाऊंगा और वहाँ proton लगाऊंगा.
नहीं, मेरे ख्याल with protons you can't do SRS. So SRS is a methodology or a technology or a technique, actually
He
combination.
says, I don't want the SRS, I want proton based therapy. Then what?
Then
Will you
can-
recommend?
then
Is
he
it
can
better?
go for some sort of,
You see, there are fellows in the audience. My question is it a real indication for proton? Is proton better for this particular patient, or what is your honest opinion?
No, not really. See, your indications for protons, where does proton really
Yes,
benefit?
please.
That's the question. Proton is a particle, whereas X-ray or gamma is actually energy. Particle has a finite movement, a finite energy, and it deteriorates after that. That is the reason why if you throw a proton particle of a certain energy, it will go to that depth and deteriorate. That is why you can save the surrounding structures. But there should be something to save. Now here your target is whole brain.
Tell me 3 indications where proton is better than the conventional. So that we can now refer for
so
proton.
I referred, first indication is pediatric tumors, where it's an internationally endorsed
So all pediatric
recommendation
tumors, fine.
in most pediatric tumors, because at the end of the day, the tumor size is not very different in the pediatric age group, but the patient size is very small.
Okay, so one is
you're-
pediatric tumor.
you can save the normal structures, one thing. Second thing is, like I referred a patient for proton, it was a lung cancer, everything controlled, but somehow at the edge, close to the spinal cord, there was some residual. So we thought that, okay, now we have irradiated, so let's save the spinal cord and some extra dose be
Okay,
given.
okay.
So that is another indication.
Anything
of
else?
Proton. Then re-irradiations, especially in head and neck, especially in same areas, not in new areas, that is also re-irradiation by definition, but in new areas it's probably different, but in the same areas, yes, it will make a lot of difference using proton.
To
But no
summarize,
stereotaxy.
pediatric tumors, to summarize, the tumors which are close to vital organs,
Yes.
and re-irradiation in an already re-irradiated area.
Yes,
That's the three indications
these
for
will
proton.
be
So
very good,
that is
yes.
something for the audience. Now, for the medical oncologist, he has done the SRS. What is? You
But
will
why
change
for
the system.
SRS? I'm not very convenient for SRS because even though it is a 3 lesion, it is a very aggressive disease. I will change the systemic therapy rather than going for SRS. Anyway, it will come in any other place.
So you will not give the radiation, and you will
If
change the
patient
systemic
is
therapy.
asymptomatic, I will not do radiation.
So you will wait for him to throw seizure while he's driving.
Why small Chintus lesion 1 centimeter, less than 1 centimeter going to cause seizure?
Same. So what is the size at which you will say no, I cannot wait?
Patient is symptomatic. When the patient is
So
symptomatic,
that's what I'm
for the
saying.
brain
You will
metastasis-
wait for the
Right.
symptoms to occur one fine day,
So,
and symptoms
but
may occur at 1 a.m. in the
I'm
night.
changing that is the reason I'm changing the systemic therapy, right?
How much is
So,
your systemic
so
therapy
let us
going to affect the brain?
let us continue this discussion. So you think the patient is already on systemic therapy, whose systemic therapy has controlled the disease, can control the brain mets when he has progressed on systemic therapy only in the CNS.
No, I'm changing the line of therapy, thinking that it will control the disease over that place.
So you think that the second line drugs are better to control the brain mets in a small cell lung cancer, where sometimes we talk about PCI.
So here the patient is platinum sensitive disease because the patient almost 8 months is there. I will go and re-challenge platinum again. That is definitely a viable option for this patient.
And that,
And
according to you, will take care of the brain mets.
Yes.
Anybody else?
No, we don't agree with that.
Any other medical oncologist wants not to or wait for the radiation and change the
SRS
system?
definitely. At least whole brain RT is also okay. Why you want to go for SRS in this situation?
So your objection now has changed from no RT to whole brain RT.
At least
You are-
whole
you are
brain, but
against
not,
only
definitely
SRS.
not SRS.
Okay, so you are saying at least whole brain RT should be given, but no SRS.
Yes.
What about you? Anybody says no RT and only change systemic therapy?
Sir, definitely RT. Now, as Dr. Gagan
Okay,
said,
definitely RT, whichever RT the
Yeah.
radiation oncologist will decide.
and I would
Okay.
like to continue IO and closely observe because we don't have much option in this biology.
Okay, so because the more likely question of medical oncologist is that if the radiation oncologist is decided to give an radiation, whatever form that he wants to give, will you change the therapy or you will continue the same
At this
therapy?
point of time, no. Closely observe and systemic progression apart from brain will change.
Anybody, Dr. Amberson, will change the therapy? You have given whole brain RT. The radiation oncologist agreed to you, he has given whole brain RT. Now, will you change the systemic therapy because of the brain mets or you will wait for the systemic mets to occur?
See, sir, whatever I have observed is when the disease biology we have to take into the account. If the disease biology is when we have a good option for the patient, like in HER2 positive disease.
No,
That is-
I'm talking about this.
I'm telling you, when
Small
the-
cell, what you will do in this patient?
in this patient, definitely I change the systemic therapy.
So you have given atizo, you have given chemo, you have given lurbinectedin also. Now
I
what you will
re-challenge
change
with
to?
platinum. I re-challenge with platinum.
Re-challenge with platinum. Anybody else who's saying that? So how many for changing, continuing the same IO? You, what you will do? You are not raising hand for anything.
Continue IO.
Continue. What about you?
I would like to reintroduce systemic therapy.
So
Because
3 has
we-
to 2. 3 has to 2. So let us see the data. Okay. So of course the whole brain RT versus SRS that Gagan has discussed. Higher rates of CNS pregnation with SRS, but no determinant to overall survival. So you can choose either of it. Now, what is your opinion about this hippocampal avoidance of PCI? This is specifically
Yes.
your particular topic.
Yes, this is what I was talking about, that you can do some hippocampal. Actually, this is a little bit overstated, hippocampal avoidance, I will say for this thing, because the only way it was endorsed and it has come into fore is because they did some this mini mental state examination, and you know, some benefit was seen with the hippocampal sparing.
Do you favor this in your practice, hippocampal sparing?
I know we are late, but I think these 2 points I'm going to make are relevant to an understanding communication between the radiation and medical oncologists. So the reason why hippocampal avoidance came to fore was because of that paper for MMSE, where the relative decrease was lesser with hippocampal avoidance. Hippocampal avoidance did not make the patient completely okay.
So you don't give it
First thing.
routinely?
Sorry?
You don't do it routinely?
I do it. And then the second thing, very important. Hippocampus is very small. It is as much the size that I'm making with my finger. So when you are doing it with radiation, to totally spare it and, you know, keep the dose right up to that hippocampus is something which is not so simple. So the actual benefit of hippocampal avoidance is not really very well known. Yes, we do it for patients in whom somebody will, suppose you will insist that, okay, whole brain has to be done, let's forget SRS.
Okay.
Or a patient like this one says, no, I don't want SRS, but we know everything is fine. I will do hippocampal avoidance.
Fine. So now for those who have chosen to have the same treatment, systemic therapy, after another 4 months, patient has now bone mets, reappearance of liver mets, PS is still 1, what you will do? Now Dr. Amberson, will you, now 8 plus 4, 12 months have gone. Will you still re-challenge or you go for second line?
I change it to second line.
You will go to second line now?
Yes.
So initially we were going to...
Initially also, if the option is there, I will go change it to second line only, because I have the experience that in extensive disease or such a bad biology, immunotherapy continuing is not going to change a meaningful.
So as he has said, rightly said, we have some data of re-challenge with platinum-based therapy, and especially if your patient is not affording for the newer drugs, then you can have this re-challenge based upon what is the initial PFS. Anything above 6 months, if the patient has a reasonable control, you can re-challenge with the platinum drugs. And there are retrospective data, there is some prospective publication also, and there is some benefit, almost 2 months benefit of PFS and OS. Of course, lurbinectedin is the approved drug if he is not taken in maintenance, and we all know the data. But this is the new drug that everybody is talking about, and Delphi 301. This is the paper which was presented in this ASCO also, and now it has got approval. So anybody has used this amongst the medical oncologists? Anybody in the audience? Viraj gets all fancy drugs? No, he gets only for GI, not for small cell lung cancer. So yes, this is the next in-line drug. This is the DDL3 inhibitor. They say that there is some correlation with DDL3 expression, but as PDL1 is, this also is not a perfect biomarker, and eventually this will come to India, and eventually our patients also who are affording will start asking for this drug. So I have put this here. Now the last slide. Now we are discussing about the extensive stage, but we all know that in early stage also or limited stage also there is a role of IO. So we give chemo plus CTRT plus IO maintenance. So now if that patient unfortunately progresses, how will you treat? So patient has used IO in an early stage maintenance, Adriatic trial, and now he has relapsed, unfortunately. So what you will do? You will directly go for topotecan, you will directly go for lurbinectedin or tarlatamab, or you can re-challenge the IO.
Re-challenging IO, I'm not very favorable for it. IO is a little bit weak drug only for me.
Then
especially
what will
when
do?
we use in extensive stage disease or in recurrent setting, that is a really weak drug. It isn't showing good response when we use in early stage or locally advanced. That's why the trend is now more using in a locally advanced or early stage disease. In extensive stage disease, even if we use in extensive stage disease, the drug effect is very, very small.
So my
I
question
won't
is,
consider for re-challenge of immunotherapy in that scenario. I will again see for the disease-free interval for the patient. Here the disease-free interval is really good, then again I consider for re-challenge with platinum-based therapy. If the disease-free interval is not that great, then I would go for another option.
okay. So why I put this slide? Because this situation is going to come, because Adriatic trial is already approved and it's a good data we are all using. And there is a very beautiful paper which I want the fellows to go through. Systemic therapy for small cell lung cancer, ASCO guidelines, rapid recommendation. They have updated their guidelines on what they have said that if the disease-free interval is more than 6 months, you can re-challenge both the chemo as well as the IO as per the guidelines. See, unfortunately, there is no evidence for that. And we have seen this situation in most, say in breast cancer also. CDK inhibitors were given metastatic setting, now they are given in an adjuvant maintenance. So the re-challenge thing will never have a robust data, but general principle is that longer the duration of control, we can re-challenge. And that's what the guideline says, that if you have 6 months is an arbitrary number they have taken, so 6 months or more than 12 months, so definitely 6 to 12 months, yes, less than 6 months, no. That is the rough take home. You want to ask?
When he was saying now that he will change the line by the moment the 3 metastases appear, I wanted to ask you actually that.
No, we don't. Generally, in my practice, I will not change.
Yeah, that, is there merit in considering that if you have achieved the average progression-free survival of the IO that the patient is on, would there be merit in changing it then? Just asking.
So my
because similar thing is being endorsed here as well.
So my practice here is that I will of course happily ask the radiation oncologist to take care of the brain mets by whichever way he wants to do. If the patient is systemic control, I will continue what that is being going on and keep the other options, subsequent options for systemic progression, because I have very less options. All these drugs are not available with me. So that's what I will do in my practice. So I think we are already running out of time. So this is the key takeaway points which are taken from the ASCO, and that's all. Anything from the audience or anything that you want to ask, please ask. So I'm happy. Of course, I show my Twitter handle. Nowadays, I show my OncoWisdom WhatsApp group also.
Sir, one doubt.
Yeah, please.
Sir, patient extensive stage small cell lung cancer. Initially, he was not referred for the immunotherapy.
Initially?
Not referred for immunotherapy. He received carbohydrate only. Now progression 4 months. Now he got the credit approval, or he currently for everything. So can you give IO with chemo second line?
Okay, so answer is very simple. The single agent IO is already approved as a second line drug in those patients who has not received IO before. So yes, we can give IO. Whether you will give chemo again when there is a 4 months disease free interval, answer is no, because for the platinum or the platinum based chemo to work again, at least 6 to 12 months PFS has to be there. But IO can be given as single agent in second line.
No, within 4 months.
So within 4 months, if he has progressed, no chemo, only IO, or the other drugs.
No second line chemo with IO, just immunotherapy.
So second line chemo in combination with IO has not been studied. Okay. You can give second line chemo itself, topotecan you can give, irinotecan you can give, or you can give IO as a single agent. Okay. Combination of the both is not yet studied, and there is no data for that. Panelists agree, right? Yeah. Thank you. Thanks. So that's it. We have finished, and sorry for taking slightly extra time. Thank you.